The female pelvic cavity is divided into an anterior, middle and posterior compartment in contrast to the malopelvic cavity, which is confined to two compartments and contains parenchymatous organs, e.g. prostate and seminal glands. All three female compartments consist of hollow visceral organs resting upon the pelvic floor: anterior compartment, urinary bladder and urethra; middle compartment, uterus with uterine adnexa and vagina; posterior compartment, rectum and anal canal. The peritoneum covers the organs contained in the subpelvic compartments from above. While the urinary bladder and rectum are only partially lined by peritoneal serosa, almost the entire uterus and the complete adnexa, including the ovaries and uterine tubes, are wrapped by peritoneum and, thus, readily accessible by transperitoneal approach. The peritoneum reflects from the uterine body anteriorly onto the fundus of the urinary bladder, forming the vesic-uterine pouch delimited laterally by the vesicuterine folds, and posteriorly onto the rectal wall, forming the rectuterine pouch delimited laterally by the rectuterine folds. Except for the posterior vaginal fornix directly facing the rectuterine pouch, the vagina is located extraperitoneally. Both peritoneal pouches are often filled with small intestinal loops, sigmoid colon or greater omentum, thus requiring proper exposure by moving the content upwards. The pelvic compartments are separated by septa, mainly composed of connective tissue and intermingled smooth muscle tissue between the anterior vaginal wall and both the urinary bladder and urethra extends the vesico-minus urethrovaginal septum. Between the posterior vaginal wall and the anterior rectal wall extends the rectovaginal septum. The connective tissue septa are devoid of major blood vessels and serve as separating gliding layers between the three pelvic compartments, reflecting the different ontogenetic origins of the urinary, genital and digestive tract. Thus, if surgical dissection follows these cell-F opening planes between the pelvic compartments, the uterovaginal complex can be readily delineated from the urinary bladder and urethra anteriorly and theanorectum posteriorly without relevant bleeding risk. The female pelvic floor is of larger dimension than in males, displaying a wider urogenital opening, although its muscle strength is generally lower and its nerve supply less developed. These peculiar features allow vaginal delivery, but also predispose to a higher susceptibility for structural and functional insufficiency and pelvic organ prolapse. The pelvic floor is composed of a pelvic diaphragm consisting of the levator ani muscle and a urogenital diaphragm comprising the transverse perineal muscles. The levator ani muscle corresponds to a flattened and funnel-shaped muscle closing most of the lower pelvic aperture. However, along the ventral midline openings are left forth urethra and vagina, urogenital hiatus, and the anal canal, anal hiatus. The largest portion of the levator ani muscle are the aleococcygeal muscles extending from the pelvic side walls to a midline raphe. The rather thin muscle layer originates at the tendinous arc of the levator ani muscle, formed by condensed connective tissue of the obturator fascia, white line. The hammock-shaped pubo-coccygeal muscle originates from the pubic bone and extends towards the coccygeal bone, whereas the sling-shaped puborectal muscle bends around the anal canal to produce the anorectal angle. Innervation of the pelvic floor muscles is mainly provided by infralevatory branches of the pudendal nerve. In addition, also direct nerve branches from sacral spinal nerves S3, S4 contribute and extend from the sacral concavity to reach the levator ani muscle from above. Thus, when exposing the pelvic floor muscle during extended deep lymphadenectomy, care must be taken to preserve these direct supralevatory nerve branches. The uterus is a pear-shaped hollow muscular organ of 7 to 9 cm length with its long axis nearly at right cornu inserts.
The uterine adnexa comprise the ovaries, ovarian tubes and ligaments adjacent to the uterus on both sides. The ovaries lie in the ovarian fossa posterolateral to the uterus and medial to the external iliac vessels. They are attached to the uterus by the ovarian ligaments extending from the uterine pole of the ovary to the uterine cornu. The peritoneal fold raised by the ovarian ligament corresponds to the mesovarium containing the ovarian branch of the uterine artery. The tubal pole of the ovary is connected to the fimbriated of the uterine tube. Between the tubal pole and the dorsolateral pelvic wall extends the infundibulopelvic ligament corresponding to a peritoneal fold raised by the ovarian blood vessels. The synonym suspensory ligament of the ovary is inadequate, as the ovary is not substantially suspended by this peritoneal duplicature. When mobilizing the uterine adnexa, attention should be paid to the fact that the infundibulopelvic ligament together with the ovarian blood vessels cross the external iliac blood vessels ca 1-2 cm anterolateral to the ureter. Moreover, due to its considerable intraperitoneal mobility, the ovary may come into close proximity to both the external and internal iliac vessels and the ureter at the pelvic brim. The uterine tube is ca 9 to 11 cm long and connects the tubal pole of the ovary with the uterus. The infundibulum of the uterine tube is funnel-shaped and displays several fimbriae, which the ovarian fimbria is attached to the tubal pole of the ovary. The widened ampulla shows a luminal diameter of up to 10 mm and narrows at the isthmus to 0.1 to 0.5 mm. The uterine or intramural portion of the uterine tube is ca 10 mm long and opens into the uterine cavity via the uterine os located at the uterine cornu. The peritoneal fold raised by the uterine tube corresponds to the mesosalpinx and contains the tubal branch of the uterine artery. Fixation of the uterovaginal complex is achieved on the one hand by the support of the pelvic floor. There is still an ongoing discussion about the exact tissue composition, topographic anatomy, functional relevance, and terminology of these ligamentous, parauterine structures. Broad ligaments. The broad ligaments are named according to the fact that they provide a wide-stretched and ample connection between the middle pelvic compartment and the pelvic side walls. The peritoneal covering is lifted up by the broad ligaments and descends anteriorly to cover the paravesical space, anterior leaf, and posteriorly to cover the pararectal space, posterior leaf, on both sides. When viewed from above, the broad ligaments display 3 peritoneal folds on each side converging from different origins of the inner abdominal and pelvic walls towards the uterine cornu. Funicular meso, anterior fold, mesosalpinx, middle fold, mesovarium, posterior fold. The funicular meso corresponds to the peritoneal fold raised by the uterine round ligament extending from the uterine fundus below and lateral to the uterine cornu to the deep inguinal ring. The fibromuscular bands pass along the paravesical fossa and are accompanied by a branch from the uterine artery and lymphatic vessels draining to superficial inguinal lymph nodes. The mesovarium and mesosalpinx have been described previously. See section uterine adnexa, parametrium and transverse cervical ligaments. Beneath the peritoneal covering, the broad ligaments consist of condensed connective tissue connecting the pelvic sidewalls with the uterus, parametrium, and the vagina, pericarpium, comparable to those densifications of connective tissue extending lateral to the urinary bladder, pericystium, and rectum, periproctium. The fibrous tissue contained within the parametrium/pericarpium corresponds to the transverse cervical ligaments, cardinal ligaments, which predominantly attach to the uterine cervix and vaginal fornix. Although composed of connective tissue. Uterosacral ligaments. The uterosacral ligaments attach to the uterine cervix and upper vagina and are often confluent with the uterine insertion site of the transverse cervical ligaments. The fibrous bands extend dorsally along the rectal sidewalls to reach the sacrum. On their way to the sacrum, they create the rectouterine folds and fan out before inserting at the sacral vertebrae S2, S4. The uterosacral ligaments serve as suspension of the uterine cervix and the vaginal tube, ensuring the craniodorsal orientation of its long axis. In close proximity extend autonomic nerve fibers of the inferior hypogastric plexus passing immediately lateral to the uterosacral ligaments. Pubocervical ligaments. The pubocervical ligaments connect the back side of the pubic bone with the uterine cervix. On their way to the uterus, the pubocervical ligaments diverge around the urethra and bladder neck. In fact, all uterine ligaments. Transverse cervical ligaments from both sides, uterosacral ligaments from behind, and pubocervical ligaments from front, insert at the uterine cervix. The insertion site is reinforced by a connective tissue condensation radially running around the uterine cervix, termed cervical ring or pericervical fascia. Mesometrium. The term mesometrium refers to the embryologically defined tissue compartment of the middle pelvic compartment that Contains the neurovascular supply and major lymphatic drainage routes of the uterus, comparable to the mesorectum. Wrapped around the rectum in the posterior pelvic compartment. The mesometrium actually corresponds to the parametrial tissue, however further emphasizing its mesentery-like function provided by the lymphopathy tissue, and accompanying uterine blood vessels and its clear delineation by facial envelopes preventing early tumor transgression. The clinical significance of the mesometrium has received special attention after the introduction of total mesometrial resection, TMME, for uterine cancer, in turn comparable to total mesorectal excision, TME, carried for rectal cancer or complete mesocolic excision, CME. Recently introduced for colon cancer. All these surgical approaches are commonly based on the concept that tumor spread is initially confined to permissive ontogenetic compartments and its corresponding LYMH node basins, so that complete removal of these embryologically defined packages will result in both optimal tumor control and low morbidity if the resection margins are properly respected. The uterine tubes, uterus, and upper vagina are derivates of the paramesonephric ducts, Müllerian ducts. The distal fusion of the Müllerian ducts induces the development of the uterovaginal canal and the formation of the broad ligaments and the mesometrial tissue. According to Hockel, the mesometrium can be subdivided into a vascular mesometrium containing the uterine vessels and surrounding lymphopathy tissue with mesometrial lymph nodes and a ligamentous mesometrium corresponding to the uterosacral ligaments and rectovaginal septum. Blood vessel supply of female pelvic viscera. The female pelvic viscera are mainly supplied by the internal iliac arteries. The common iliac arteries originate at the aortic bifurcation in front of the left side of the fourth lumbar vertebra. They pass along the medial borders of the psoas major muscle without giving off branches and diverge into external and internal iliac arteries, whereas the external iliac arteries follow the psoas major muscle until traversing the lacuna vasorum through the femoral ring to reach the lower limb. The internal iliac arteries descend into the pelvic cavity in posterocaudal direction over ca 4 cm and then divide into an anterior and posterior trunk to expose the inter-NAL iliac artery, the adjacent and sometimes overlying infundibulopelvic ligament and ovary have to be shifted upwards. The common, external, and internal iliac veins are located medially or dorsomedially to their arterial counterparts. The anterior trunk or division of the internal iliac artery comprises the following branches. Superior vesical artery. The superior vesical artery and is the first visceral branch and corresponds to the proximal, patent segment of the fetal umbilical artery. The artery follows the pelvic sidewall medially to the obturator, vessels and nerve, and craniolaterally to the urinary bladder. Before reaching the urinary bladder, the superior vesical artery splits into various branches, mostly for the vesical fundus and corpus but also for the distal ureter. The obliterated segment corresponds to the medial umbilical ligament ascending from the vesical fundus along the anterior abdominal wall to the umbilicus, thereby forming the medial umbilical fold. Underneath the parietal peritoneum, gentle traction applied to the medial umbilical ligament allows easy identification of the superior vesical artery and usually thereby also of the uterine artery, as both arteries originate either from a common trunk or close to each other. Uterine artery. The uterine arteries supply the entire uterus, including the uterine tubes and uterine round ligaments, and also the upper third of the vagina. The uterine artery originates from the internal iliac artery either as a separate branch or as a common trunk, together with the superior vesical artery. Although the sup. Rear vesicle and uterine arteries supply different pelvic compartments. Vesicovaginal anastomoses are often observed, in particular regarding the corresponding veins. The uterine artery runs through the parametrial tissue, covered by the broad ligament towards the uterine cervix. The ureter crosses underneath the uterine artery ca 1 to 2 cm, lateral to the uterine cervix and lateral vaginal fornix, and receives a supplying branch. Whereas in most of the cases, one single uterine artery is present on each side, multiple uterine veins of different sizes can be observed which drain the uterine venous plexus. The uterine veins often do not directly follow the course of the uterine artery, but often pass underneath the ureter. The most caudally located vein is also termed deep uterine vein. The main branch of the uterine artery ascends lateral to the uterus in meander-like course towards the uterine cornu, where it gives off an ovarian branch running within the mesobar and a tubal branch running within the mesosalpinx. These branches establish anastomoses with the ovarian artery. An additional branch originates at the uterine cornu to follow and supply the uterine round ligament. From the tortuous segment of the uterine artery, multiple helicin branches enter in the uterine wall, divide into arcuate arteries and supply the myometrial and endometrial layers by giving off radial and spiral branches. The right and left uterine arteries establish extensive intramural anastomotic connections across the midline so that the uterine blood supply is not seriously compromised after unilateral ligation. At the level of the uterine cervix, branches descend to the vagina and anastomose with branches of the vaginal artery to form two longitudinal vessels. These vaginal azygous arteries run along the anterior and posterior vaginal wall. Vaginal artery. In addition to vaginal branches of the uterine artery, one or more arteries originating from the internal iliac artery directly run to the vagina. These vaginal arteries correspond to the inferior vesical artery in males and supply the vagina, vaginal vestibule as well as the vesical trigone and urethra. Middle rectal artery. The last visceral branch of the internal iliac artery is the middle rectal artery running above the levator uni muscle within the lateral rectal pedicles together with autonomic nerve fibers of the rectal plexus to reach the rectal wall. However, in contrast to both the superior vesical and uterine arteries, the middle rectal arteries are much smaller in size and inconstantly present, as the rectal blood supply is mainly provided by the more prominent superior rectal artery running within the mesorectum. Obturator artery. The obturator artery is one of the first branches of the internal iliac artery. However, it does not primarily supply the pelvic viscera, but leaves the pelvic cavity via the obturator canal to approach the adductor muscles of the medial thigh. In the pelvis, the artery passes medially to the internal obturator muscle and caudally to the obturator nerve, which converges with the obturator vascular pedicle at the entrance foramen of the obturator canal. At its proximal segment, the obturator artery is located in close proximity both to the ureter and the ovary, and it gives off iliac branches supplying the iliopsoas muscle. From the distal segment, vesicle branches may ramify and pass medially to the urinary bladder. Frequently, an anastomotic connection between the obturator and inferior epigastric artery is provided by a pubic branch running across the pubic bone over the pectineal ligament. A prominent pubic branch is also termed corona mortis, crown of death, because in earlier times an inadvertent injury of this vessel during inguinal or femoral hernia repair has led to serious bleedings. In up to 1/3 of cases, the obturator artery does not originate from the internal iliac artery but from the inferior epigastric artery or even the external iliac artery, sending an enlarged pubic branch directly towards the obturator canal. In any case, special attention should be paid to these vascular variations when operating in the obturator fossa and paravesical space, e.g. for extended pelvic lymphadenectomy. Internal pudendal artery. The internal pudendal artery is one of the terminal branches of the anterior division of the internal iliac artery and supplies the perineal region, anal canal, external genital organs, and pelvic floor muscles. The artery descends laterally in front of the piriformis muscle and sacral nerve plexus roots, leaves the pelvis through the infrapiriform hiatus of the greater sciatic foramen and bends around the ischial spine to enter into the ischioanal fossa via the lesser sciatic foramen. The artery is accompanied medially by the internal pudendal vein and pudendal nerve. Branches of the internal pudendal artery include muscular branches for the pelvic and gluteal region, inferior rectal artery, perineal arteries. Posterior labial branches, branches to the vestibular bulb, and vaginal introitus, deep and dorsal artery of the clitoris. Inferior gluteal artery. The inferior gluteal artery of the internal iliac artery, however often originating from a common stem together with the internal pudendal artery. It also decans anterior to the piriformis muscle and sacral nerve plexus, but then passes posteriorly between the ventral rami of the sacral spinal nerves and traverse the infrapiriform hiatus of the greater sciatic foramen to reach the gluteal and posterior femoral region. The posterior trunk or division of the internal iliac artery comprises the following branches. Iliolumbar artery. The iliolumbar artery is the only ascending branch of the internal iliac artery passing posterior to the external iliac vessels and obturator nerve in front of the sacroiliac joint to reach the psoas muscle. The iliac and lumbar branches supply the muscles of the corresponding regions and establish anastomoses with the gluteal and deep circumflex iliac arteries. Lateral sacral arteries. Usually a superior and inferior branch originate from the internal iliac artery, descend and approach the anterior sacral foramina to supply the sacral canal and dorsal sacral region. The lateral sacral arteries anastomose from both sides with the median sacral artery. Superior gluteal artery. The superior gluteal artery corresponds to the terminal branch of the posterior division of the internal iliac artery. Immediately after its origin, the large vessel traverses between the first ventral rami of the sacral spinal nerves to leave the pelvis via the suprapiriform hiatus of the greater sciatic foramen. Deep and superficial branches of the superior gluteal artery supply the gluteal and sacral region and anastomose with the inferior gluteal, deep circumflex iliac and circumflex femoral arteries. Pelvic veins. As a general rule, larger veins such as the common, external, and internal iliac veins follow the course of their arterial counterparts. In most cases, the veins run medially or dorsomedially to the arteries. The same observation holds true for most of the parietal branches, e.g. obturator, pudendal, gluteal veins, of the internal iliac artery, whereas the visceral branches display different features. The urinary bladder, uterus and vagina are drained by venous plexus which are interconnected with each other and release the blood into multiple vesical, vaginal, and uterine veins. These veins do not strictly accompany and parallel the arteries until they have entered into the internal iliac vein. It has to be emphasized that during laparoscopic or robot-assisted surgery, pelvic veins often collapse due to the interperitoneal pressure exerted by gas insufflation onto the thin venous walls. Thus, special care must be taken to clearly identify and respect the pelvic veins, because injury may occur inadvertently and lead to troublesome bleeding. sometimes only evident after diminishing the intraperitoneal pressure. Lymph nodes and lymphatic drainage of the uterus and uterine adnexa. In general, lymphatic drainage follows the blood supply of the corresponding organs and is realized by a network of rather thin-walled lymphatic vessels and lymph nodes, grouped along the nutrient vascular branches and enveloped by fatty and loosely arranged connective tissue. As the arterial supply of the uterus and uterine adnexa originates from two sources, uterine and ovarian arteries, the main lymphatic drainage involves both pelvic and para-aortic routes, and is therefore complex and multidirectional due to the peculiar ontogenetic anatomy of the female genital tract. However, direct lymphatic drainage pathways into the anterior pelvic compartment via the vesicouterine ligaments or into the posterior compartment via the uterosacral ligaments could not be demonstrated. Lymphadenectomy is considered to be an integral component of the surgical treatment for uterine carcinoma, due to the topographic complexity of lymphatic drainage and close proximity between lymph nodes and both blood vessels and nerves. Pelvic and para-aortic lymph node dissection are challenging and often time-consuming procedures. Therefore, profound anatomical knowledge of the different lymph node regions is required to be familiar with the anatomical landmarks, which help to identify and preserve structures at risk when removing the areolar fibrofatty tissue pads harboring the relevant lymph nodes. The pelvic lymphatic system is composed of parietal lymph nodes and trunks following the major pelvic blood vessels and of organ-related lymph nodes intercalated into the different mesenteries supplying the pelvic viscera. The following pelvic lymph node compartments or basins can be described. External iliac lymph nodes. The external iliac lymph basin, and extends from the common iliac bifurcation down to the femoral ring along the psoas muscle. The medial border of the compartment is defined by the paravesical and obturator fossa. Lymph nodes may be further subdivided into a lateral group located between the external iliac vessels and the psoas muscle, an intermediate group between the artery and vein, and a medial group between the vein and the pelvic sidewall. Structures at risk during lymph node dissection are the external iliac vessels, in particular the vein when lifted up for harvesting medial lymph nodes, and the genitofemoral nerve when harvesting lymph nodes lateral to external iliac vessels. In some instances, minor branches originating from external iliac vessels to supply the psoas muscle may be torn and bleed during lymph node removal in this compartment. Internal iliac lymph nodes. Internal iliac lymph nodes follow the anterior and posterior trunk of the internal iliac artery and its corresponding branches, thus collecting lymphatic fluid from parietal/somatic structures, e.g. gluteal, perineal, sacral regions, as well as visceral organs, e.g. bladder, uterus, rectum. The compartment originates at the common iliac bifurcation and extends dorsally onto the piriformis muscle, caudally down to the levator ani muscle and ventrally to the origin of the visceral arterial branches for the urinary bladder and uterus. Most important for lymph node dissection is the direct vicinity of both the ureter and the delicate branches of the inferior hypogastric plexus approaching the internal iliac branches and lymph nodes from the medial side. Common iliac lymph nodes. The common iliac lymph nodes and drain the external and internal iliac lymph nodes and follow the common iliac vessels towards the aortic bifurcation. Like the external iliac lymph nodes, they can be further subdivided into a lateral group facing the iliolumbar fossa, an intermediate group intercalated between the common iliac vessels adjacent to the lumbosacral trunk, and a medial group located along the pelvic brim underneath the common iliac vein. Structures at risk during lymph node dissection are the genitofemoral nerve on the lateral side, the lumbosacral trunk and obturator nerve at the dorsocaudal aspect, and the ureter crossing the common iliac bifurcation. Presacral lymph nodes in front of the promontorium and underneath the aortic bifurcation. The bilateral common iliac lymph routes drain into presacral lymph nodes, and also termed promontory, midsacral, or subaortic lymph nodes. The presacral compartment extends from the aortic bifurcation down to the end of the second sacral vertebra. Structures at risk during lymph node dissection are the median sacral artery and the presacral venous plexus, as well as the thin-walled common iliac veins, in particular the left one due its exposed course running above the promontorium. Moreover, the promontorium region is crossed slightly left by the superior hypogastric plexus, giving off the hypogastric nerves on both sides. Obturator lymph nodes. The obturator lymph nodes are distributed within the areolar fibrofatty tissue pad, extending along the pelvic sidewall formed by the internal obturator muscle, the tendinous arcs of levator ani muscle, and parietal pelvic fascia, and the levator ani muscle itself. The upper border is defined by the pelvic brim and the external iliac vessels, the dorsal border by the common iliac bifurcation, and the medial border by the visceral branches of the internal iliac artery. The obturator fossa is traversed by the neurovascular obturator pedicle, composed of the obturator nerve, recognizable by its pearl-white color, and the obturator artery and vein which join the nerve coming from below. The neurovascular obturator pedicle enters into the obturator canal beneath the superior pubic branch and frequently displays a pubic branch anastomosing with the inferior epigastric artery. Lymph nodes in this compartment may be further subdivided into superobturator, superficial, and infraobturator deep lymph nodes according to its position related to the obturator pedicle. Complete lymphadenectomy of the obturator fossa requires also subtle clearance of infraobturator nodes located below the obturator pedicle and along the upper surface of levator ani muscle. However, care must be taken not to injure the obturator pedicle itself, as well as the neurovascular pedicles of the urinary bladder, in particular the vesical venous plexus. Obturator and internal iliac lymph nodes may also be subsumed as paravisceral lymph nodes, as they are located adjacent to pelvic visceral organs which they drain, that is the urinary bladder and the uterus. Parametrial/mesometrial lymph nodes. Those lymph nodes located in close topographical vicinity to the uterus underneath the broad ligament, parametrium, and intercalated into the uterine mesentery, mesometrium, correspond to the parametrial/mesometrial lymph nodes. They are embedded in areolar fibrofatty tissue and follow the branches of the uterine artery. Vascular mesometrium. On the one hand, the aim of oncologic surgery is to completely remove these organ-related lymph nodes. On the other hand, the vesical neurovascular pedicle supplying the urinary bladder and the ureters crossing the parametrial compartment have to be preserved during lymphadenectomy of the parametrial/mesometrial tissue. The paraortic lymphatic system, composed of the lumboaortic lymphatic chains, extends beyond the pelvic lymph nodes and may be affected by lymphatic spread of tumors involving the uterine body and/or fundus and uterine adnexa. In these cases, lymphadenectomy should include removal of the lymph routes following the infundibulopelvic ligament and the ovarian vessels up to the paraortic lymph basins. The following paraortic LYMH node compartments can be described. Inframesenteric lymph nodes. Inframesenteric lymph nodes extend from the origin of the inferior mesenteric artery along the aorta and inferior vena cava down to the aortic and caval bifurcation. The lateral borders of this compartment are defined by the ureters running in front of the psoas muscles and undercrossing the ovarian vessels. On the left side, the ureter also undercrosses the root of the sigmoid mesocolon and the inferior mesenteric pedicle, which has to be lifted up to achieve full exposure and protection of the ureter. The paraortic lymph nodes are grouped into a readily discernible ventral chains, including interaortocaval lymph nodes and less obvious dorsolateral chains. Thus, complete inframesenteric lymph node removal requires full exposure of both pericaval and periaortal tissue compartments. However, dissection should be carried out carefully, avoiding a too rigorous cleaning of the large prevertebral vessels to preserve or at least minimize the damage of the perivascular autonomic nervous network. Nerve fibers emerge from paravertebral sympathetic ganglia and form an aortic plexus composed of a left and right periaortal trunk with multiple interconnecting fibers crossing in front of the aortal wall, while the inferior mesenteric plexus follows the corresponding artery into the inferior mesenteric pedicle for the left and rectosigmoid colon. The superior hypogastric plexus descends in front of the aorta to divide in front of the promontorium into the left and right hypogastric nerves. Preservation of these autonomic nerve plexus is best achieved when both the inferior mesenteric pedicle and superior hypogastric plexus are gently lifted up to gain access to the paraortic lymph nodes. Care should also be taken to preserve the segmental lumbar arteries and veins and the small blood vessels. Approaching the ureter from the medial side. Supramesenteric/infrarhinal lymph nodes. Supramesenteric lymph nodes include those lymph nodes of the paraortic compartment located superior to the inferior mesenteric root and inferior to the left renal vein. Like in the inframesenteric compartment, supramesenteric lymph nodes are grouped around and in between the large vessels. Additionally, lymph nodes from the renal halus drain into this compartment, and autonomic nerve fibers derived from the aortic nerve plexus diverge to both sides to form the renal nerve plexus following the corresponding vessels. Autonomic nerves of the female pelvis. As pointed out in the introduction, the challenge of oncologic surgery is twofold, aiming at the highest radicalness to ensure curative therapy and lowest loss of function to maintain quality of life after surgery. The latter one depends essentially on the preservation of those autonomic sympathetic and parasympathetic nerves mediating urogenital and anorectal functions. Sympathetic nerves support the filling phase of the urinary bladder under resting conditions by relaxing the detrusor, the psyche muscle, and closing the internal urethral sphincter and bladder neck, thereby contributing to urinary continence. For controlled micturition, parasympathetic nerves suppress the sympathetic input and initiate contraction of the detrusor, the psyche muscle, and opening of the urethra and bladder neck. Thus, injury of the vesical nerve plexus may lead to both urinary incontinence and urinary bladder dysfunction. Similar actions of autonomic nerves are also exerted for the control of anorectal function, while sympathetic nerves contribute to fecal continence by mediating internal anal sphincter contraction and rectal filling. Parasympathetic nerves initiate defecation by relaxing the internal anal sphincter and enhancing rectal motility. Moreover, both sympathetic and parasympathetic nerves are involved in regulating sexual functions. Sympathetic nerves mediate contraction of the musculature of the clitoris, vagina, and uterus. Parasympathetic nerves are responsible for the lubrification of external genital organs and the filling of cavernous bodies, thereby inducing swelling of the clitoris. Sexual dysfunctions due to surgically induced pelvic autonomic nerve injury are generally more evident in male patients, e.g., leading to erectile dysfunction and impaired ejaculation. However, the impact of autonomic nerve damage In female patients, such as inability to experience orgasm and insufficient lubrication should not be underestimated. The extent of autonomic nerve injury that will result in definite postoperative impairment of urinary and fecal continence, as well as sexual functions, remains unclear. The autonomic innervation of pelvic organs is characterized by its functional redundancy, anatomically reflected by a bilateral organization of interpelvic nerve plexus abundantly ramifying and connecting both sides with each other. Thus, partial or unilateral damage may be compensated by the remaining intact contralateral nervous input. Sympathetic nerves. The preganglionic sympathetic nerve fibers emerge from lower lumbar and upper sacral spinal cord segments and pass along the descending aorta on both sides as periaortal trunks. The periaortal nervous network fuses ventrolaterally to form the inferior mesenteric and superior hypogastric plexus in front of the promontorium and slightly left to the midline. The superior hypogastric plexus divides into the left and right hypogastric nerves. The hypogastric nerves often consist of various nerve bundles and are embedded within the parietal pelvic fascia extending in front of the sacral concavity. Gentle traction of the hypogastric nerve will lift up this facial sheath in a tent-like fashion, thereby illustrating its course along the pelvic side wall down to the inferior hypogastric plexus. Parasympathetic nerves. Parasympathetic nerves derive from the sacral part of the parasympathetic nervous system residing in the sacral spinal cord, together with ventral branches of the sacral spinal nerves S2 S4. These pelvic splanchnic nerves leave the ventral sacral foramina and pierce the parietal pelvic fascia on both sides to join the hypogastric nerves. The pelvic splanchnic nerves coming from dorsicaudally and the hypogastric nerves coming from dorsicranially converge to form the inferior hypogastric plexus. Inferior hypogastric plexus. The inferior hypogastric plexus is a mixed autonomic nerve plexus composed of both sympathetic and parasympathetic nerves. As this abundant nerve network provides the autonomic nerve supply to all pelvic viscera, the inferior hypogastric plexus is also termed pelvic plexus. In fact, several subgroups of delicate nerve fiber bundles diverge from the main plexus towards the different pelvic compartments to supply the corresponding organs: rectal plexus, uterovaginal plexus, vesical plexus. Like the hypogastric and pelvic splanchnic nerves, the inferior hypogastric plexus is embedded within the parietal pelvic fascia covering the pelvic sidewalls. The nervous meshwork extends medially to the internal iliac artery and follows its branches to the pelvic organs. Posteriorly, the rectal plexus diverges at the level of the rectal ligaments/pedicles and enters into the rectal wall accompanied by the middle rectal artery. Anteriorly, the inferior hypogastric plexus widens in a fan-like manner and releases a lateral and medial trunk. The lateral trunk corresponds to the vesicle plexus running to the bladder lateral and underneath the ureter. The nerve bundles follow the branches of the vesicle artery and further ramify to innervate the distal ureter, urinary fundus and neck, and internal urethral sphincter. The medial trunk corresponds to the uterovaginal plexus passing to the uterine cervix and vagina medial and underneath the ureter. The nerve bundles follow the uterine artery after its intersection with the ureter and innervate the uterus and urinary bladder from both sides. Ureter. Special attention should be paid to the topographic anatomy of the ureter due to its high vulnerability to intraoperative injury for the following reasons. Considerably long course, 25 to 30 centimeters, along the interface between the retro-und intraperitoneal space exhibiting segments susceptible to damage at virtually all levels. Hampered identification caused by obesity, previous surgery, or radiation, inflammatory or neoplastic events. Scarce peristaltic movements. Morphological appearance and size similar to vascular structures. Relatively common congenital anomalies, e.g. ureter duplex, ureter physis, crossed ureter, retrocaval ureter. Abdominal segment. The abdominal segment extends from the renal pelvis to the pelvic brim in front of the psoas muscle. The course of the ureter may vary from a paravertebral position close to either the vena cava or aorta to a lateral position along the outer border of the psoas muscle. The ureter is crossed anteriorly by the ovarian vessels and posteriorly by the genitofemoral nerves. On the left side, the ureter additionally undercrosses the root of the sigmoid mesocolon and the inferior mesenteric pedicle. In spite of the close proximity between the ureter and the digestive tract, both are clearly separated by the anterior renal fascia delimiting the interperitoneal from the retroperitoneal organs to which the ureter belongs, while the ovarian vessels extend further laterally to form the infundibulopelvic ligaments. The ureters run medially, creating ureteric peritoneal folds. Thus, at the pelvic brim, the ureteric fold is closely related to and located medially to both the infundibulopelvic ligament and the ovary, so that care should be taken to protect the ureter underneath its peritoneal fold when mobilizing the uterine adnexa. Pelvic segment. In most cases, the ureter enters the pelvic cavity anterior to the common iliac artery on the left side and anterior to the external iliac artery on the right side. The ureter further descends underneath the peritoneum and is related laterally to the branches of the internal iliac artery, obturator, superior vesicle and uterine artery, and the obturator nerve, and medially to the uterosacral ligament and its corresponding rectouterine fold, as well as to the inferior hypogastric plexus. Before the ureter reaches the urinary bladder via the vesicouterine ligament, the parametrium has to be traversed at the level of the uterine cervix, paracervix. The distance of the ureter from the uterine cervix and lateral vaginal fornix is ca 1 to 2 cm, while the uterine artery bends medially to reach the uterine cervix. The ureter undercrosses the vessel in anterior oblique direction. As this area is a common site of ureter injury, the distance between the ureter and both the uterine cervix and artery can be enlarged by shifting the uterus to the contralateral side, e.g. by means of a uterus manipulator. Blood vessel and nerve supply. Due to its considerable length, the ureter is supplied by various sources of blood vessels, including branches from the aorta, renal, ovarian, and internal iliac arteries. Of note is the observation that the nutrient arteries approach the abdominal segment from the medial side and the pelvic segment from the lateral side. Consequently, when mobilizing or dissecting the ureter, special care has to be taken to preserve the blood vessels at the medial side of the ureter above the pelvic brim and at its lateral side below the pelvic brim. Moreover, excessive denudation of the ureter over a long distance should be avoided to preserve the adventitial layer, together with the mesoreter, which contain an elaborated vascular plexus. Due to this intramural anastomotic system, interruption of one blood supply can be compensated by the remaining vascular sources, given that the periureteric tissue is left intact. The autonomic innervation of the ureter mediates its peristaltic movements and pain perception. The nerve fibers derive from the aortic, superior, and inferior hypogastric plexus. The distal ureter is innervated by nerve fibers originating from the lateral trunk of the inferior hypogastric plexus and running within the superior portion vesicle plexus. To prevent bladder and sexual dysfunctions due to Injury of the vesical plexus, manipulation of the distal ureter. At the region of the vesico-ureteric junction and vesical trigone. Should be avoided. Greater omentum. Both infragastric and infracolic omentectomy require knowledge of the topographic anatomy of the greater omentum. Embryologically, the greater omentum is part of the dorsal mesogastrium, which descends from the greater gastric curvature to cover the small intestinal loops and ascends back to reach the transverse colon and become adherent with the transverse mesocolon. The portion extending between the greater gastric curvature and the transverse colon is also termed the gastrocolic ligament. The gastrosplenic ligament corresponds to the continuation of the greater omentum at its left border, connecting the stomach with the spleen. Although the greater omentum is fused to the transverse colon, both structures can be separated from each other by gently detaching the adherent peritoneal surfaces. Once the greater omentum has been released from the transverse colon or the gastrocolic ligament has been split, the omental bursa is opened at a distance of approximately 1 to 2 centimeters and parallel to the greater gastric curvature. The right and left gastroepiploic arteries run within the gastrocolic ligament and give off nutrient branches to the gastric wall. Descending branches of the gastroepiploic arc traverse the greater omentum to supply both the infragastric and infracolic parts. The space between the peritoneal layers is usually filled with adipose tissue, which may be massive in obese patients. On the other hand, the greater omentum may be thin, translucent, or even congenitally absent. Beside fat storage, the greater omentum functions as a incompetent organ by means of its high content of macrophages and the ability to cover and thereby limit intraperitoneal inflammations. Anterior abdominal wall. The topographic anatomy of the anterior abdominal wall is particularly relevant when multiple trocar incisions are applied in minimal invasive techniques, bearing the risk of vascular, nerve, or organ injuries. The abdominal wall is composed of the following layers: skin, subcutaneous tissue, musculofacial layer, transversalis fascia, preperitoneal space, parietal peritoneum. Below the umbilicus, the peritoneal layer displays 5 folds. 1 median umbilical fold, obliterated uricus. 2 medial umbilical folds, obliterated umbilical arteries. 2 lateral umbilical folds, inferior epigastric vessels. The median umbilical fold is continuous with the urinary bladder fundus and sometimes stretches the urinary bladder cavity cranially, which may lead to inadvertent injury of the urinary bladder wall during suprapubic trocar placement. The medial umbilical folds separate the supravesicle from the medial inguinal fossae. Although the umbilical arteries are mostly obliterated, in some cases these vessels are still patent and may cause bleeding when the medial umbilical folds are perforated inadvertently by trocars. While both the median and medial umbilical folds converge upwards to reach the umbilicus, the lateral umbilical folds pass laterally to the umbilicus behind the rectus abdominis muscle. The lateral umbilical folds extend between the medial and lateral inguinal fossae, the latter ones corresponding to the deep inguinal rings into which the uterine round ligaments enter. The inferior epigastric vessels originate medially to the deep inguinal ring and ascend underneath the peritoneum and transversalis fascia to reach and enter into the rectus abdominis muscle. Frequently, the inferior epigastric vessels give off a pubic branch which passes along the femoral fossa and over the pectineal ligament to anastomose with the obturator vessels, whereas the transversalis fascia is ubiquitously present and most developed in the lower abdomen. The posterior lamella of the rectus sheath is only present in the upper abdomen and fades out at the level of the arcuate line. Below the umbilicus. The preperitoneal space extends between the transversalis fascia and the parietal peritoneum and is filled by fat. In obese patients, an increased content of adipose tissue may considerably thicken the preperitoneal space, which has to be considered during trocar placement to avoid unwanted insufflation of this tissue compartment.